Hello, I'm Associate Professor Peter Hendicott, the President of the World Council of Optometry, and I'd like to thank the Vision Care Association for inviting me to speak to their conference in Lebanon today. Unfortunately, I can't be there in person because I'm traveling back from Orlando in Florida from a WCO meeting to my home in Australia, Brisbane, which is where you see on the slide in front of you. So I'm going to talk a little bit about optometry education and how that needs to prepare optometry for the future challenges of eye care. So to set the scene for what we're talking about, here is WCO's concepts of optometry definition, outlining optometrist's role as a primary healthcare practitioner, where we provide comprehensive eye and vision care, including refraction and dispensing, the detection, diagnosis, and management of eye disease. And by management here, we're talking not necessarily about treating with eye diseases with drugs, but looking at deciding on whether a patient can be monitored or referred for further investigation and treatment, either by another optometry colleague or by ophthalmology. But where optometry can participate in the ongoing review and management of the progression of conditions like glaucoma or diabetic retinopathy and so on. And also, we have optometry have a role in vision rehabilitation, low vision care, etc. And part of our definition includes a statement about optometrists having a minimum completing a bachelor level degree or the equivalent to a bachelor level degree from a tertiary education institution. And it talks here about the global competency-based model of the scope of practice in optometry, and WCO is currently revising that, so this definition will be updated. So we know that there is a significant challenge about to face eye care, or currently facing eye care worldwide. And this has been well outlined in the World Report on Vision that was published in 2019. And if you haven't seen this or you haven't read it, this is an important document from optometry's perspective, and you can download it from the WHO. It talks about a range of eye conditions and a range of factors that affect eye care, but of note really are the sobering statistics that about 1 billion people have vision loss primarily because they have no access to vision care. Most of them in low to middle income countries, most of them over 50, and more than half of them women. And also the report highlights that many people have difficulties with access to vision care, particularly in areas where there is social and economic disadvantage, in rural areas, in older people, in ethnic minorities, in Indigenous people, and in women. So optometry's role really going forwards in future eye care is making sure we as a profession can improve access to care and the equity of access to care, because basically optometry is in the community. The World Report also highlights something that is quite prevalent in many parts of the world, that many of the eye problems that can be managed at a primary care level, at community level, are often things for which people seek care in secondary and tertiary settings, hospitals or so on. So the WCO is saying that building strong primary care and eye care delivered at community level can increase the efficiency of eye care services. So that's an important outcome for optometry and educators in optometry to think about. And we also should recognize that if we improve eye care, it gives improved healthcare outcomes, but it also gives improved social, financial, employment, and educational ones as well. So good eye care and access to eye care improves people's status in life and their finances and their employment and so on. So in this important aspect, we're not just talking about making people's vision better, keeping their eyes healthy, but we're also saying we can provide them with a better life and a better lifestyle. Importantly for us too, the United Nations last year, sorry, my picture's covering up the 2021, is calling on member states of the United Nations to ensure access to eye care services so that we can reduce this vision impairment load by 2030. And again, that's an important factor for optometry. We have to prepare our graduates to be able to contribute to this agenda. So if we're talking about optometric education, we really have two goals out of an optometric education program. One is to ensure that graduates are competent to undertake independent practice. And secondly, to provide the foundation in this education so that they have career-long continuing learning and continue to develop as professionals through ongoing learning, and potentially preparing them for further training in specialist areas of optometry as these may arise in the future. Orthokeratology is perhaps the most recent example of this, and in some cases, therapeutic management of eye disease. So if we think about the future agenda for eye care, and the World Report on Vision talks about the increase in prevalence and the number of people with conditions such as glaucoma and diabetes and so on, and the number of people with diabetes in the Eastern Mediterranean region is going to increase quite dramatically over the next 20 years. So optometry has a role to play in managing these people. So if we think about what education needs to provide, we need to provide optometrists in our training programs with competencies and skills in evaluating refractive error and managing refractive error. And we've had a recent initiative from WCO about myopia care, and it's not just correction, but it's mitigating the effects and so on. We need to have skills in evaluating ocular health and detecting ocular disease, and a role to play in managing ocular disease in our practices, ongoing review, checking for progression and so on. We need to have skills in assessing other visual functions, binocular vision, for example, and in vision rehabilitation for people whose vision isn't correctable with spectacle lenses or contact lenses. We need competencies in public health, understanding what causes vision problems, the social determinants of health, how to improve health literacy in the community so people are more aware of the need for eye care, how we can work with other professionals to get that message across. And we need a range of professional competencies, ethics, communication, law, and so on. So we need to think, if we're thinking about optometric education, we need to think about what we want the people who we graduate to have. We need to do that first. That's the first component. We have to think about outcomes. And in a particular country, we need all the optometry schools that are producing graduates in that country to work, or to have the expectation that they produce graduates with consistent outcomes across all the schools. So there has to be a uniform adoption of outcome statements or outcome competencies. And many countries have these. My country, Australia, has had this for a long time. So we need to define these outcome competency statements first, because we have to construct the curriculum to lead to those outcomes. We don't build a curriculum from the bottom up saying we have people who can teach physiology and anatomy and eye disease, so we'll put that in our program. We need to say, do we need to have ocular disease skills in our optometrists? And the answer should be yes. So to develop those skills, we need a certain set of background knowledge. So you build the curriculum from the top down. And so we need to prescribe the outcomes of education, because as many of you will know, and we have to recognize that there are multiple ways in which a curriculum can be developed to lead to a set of outcomes. There are multiple forms of teaching methods: traditional lecturing, problem-based learning, case-based learning, group work, and so on, and different forms of assessment, exams, multiple choice, orals, clinical skills, range of tasks, assessment tasks, all of which can lead to the development of the competencies and the evidence that graduates have developed these outcomes. So once you've got your outcome statements established and your individual schools develop their curriculum to lead to those outcome statements, you need then a system that evaluates that the courses are doing in optometry are effectively doing what they're aiming to do, produce graduates with these outcomes. So you need a process of accreditation. So I'll talk very briefly about the Australian example of accreditation. It's a quality control mechanism for optometry programs. So, as I've just said, a quality control mechanism. So, accreditation processes evaluate whether programs in Australia have prepared students for practice at entry level and are eligible for registration on graduating. In Australia, there's no pre-registration qualifying or examination process. Once someone graduates from an accredited optometry program, they're entitled to register to with our registration board to practice optometry within Australia. That's a national level board. And so these are based around a set of entry-level professional competency statements that Optometry Australia has developed. They've just redeveloped those and they're out for consultation. The Australian model of competencies is the one that the WCO's current competency model has used as its base, and we've modified our competency document just recently, so we're about to have it finalised. So in Australia and New Zealand, we have an accreditation council called the Optometry Council of Australia and New Zealand, and I used to be the chair of this body. So in our country, we don't prescribe, as I mentioned earlier, what the curriculum actually is. And that allows each school of optometry flexibility in the way they develop the curriculum. And within the quality assurance mechanisms that the university has for its own programs. And that's an expectation of the tertiary system in Australia, that universities have quality assurance systems, and our tertiary regulator audits those quality assurance systems. So the Optometry Council looks at the output for optometry schools. The tertiary regulator says, does the university have robust internal mechanisms to quality audit programs as well? So really, in our country, curriculum design and implementation, how the thing's designed and developed and delivered, is the responsibility of the schools. So our accreditation process monitors how effective the schools are and their development of the curriculum and what the curriculum is towards producing the outcome. And there's an expectation that optometry programs have formal mechanisms to put their optometry course, their optometry program, through regular review, and how that curriculum might need to be changed to respond to developments in optometry and developments in eye care. So this is a process that happens regularly by the Optometry Council, and most courses, all the courses in Australia are reviewed every 8 years by the Optometry Council, and typically most programs are reviewed about every 5 years by their own university as part of the national tertiary education requirement. So we have, if you're having a system to evaluate programs, a quality assurance system, you need something that you need some sets of standards. And in our Australian system, there are 5 areas that this looks at: patient safety or public safety, academic governance and quality assurance. So this is the university systems and the systems that the program uses to get feedback on its graduates, and how it gets feedback into the development of its curriculum from the profession and from employers and so on, what the actual program of study is, the subjects, the lectures and so on, the staffing levels, all that equipment and facilities and so on. The student experience, how are they supported through their program? How are they recruited? Are there mechanisms to support students who have difficulty, either academically or difficulty in their personal life and so on? And what the assessments models are for the program. And there's a statement about what's expected in the standard, and education providers have to show evidence that they've met these standardized statements. So there's a set of criteria under each of these domains. And I'll just show you 2 so you get the idea of what we're talking about. So this is the standard that looks at academic governance. And you can see here that the outcome statement for the accreditation body is that academic governance and quality assurance processes are effective. And it's in the criteria column, it's talking about that the provider of the university has robust academic governance arrangements in place that enable monitoring and review internally in the university. These processes use student evaluations and other evaluations and professional peer review to improve the program. And there's input from the profession into the design and management of the program. And there are ways in which, inbuilt into the program structure, there are ways in which the program can respond to new developments in optometry and in professional education. And we have standards around teaching. I'll just move my picture out of the way. We have standards around teaching, about quality and diversity of clinical training. Our expectation in Australia is that students get to see a diverse range of patients in a diverse range of settings, so they are able to practice across a range of settings when they graduate, and that teaching methods are appropriate to achieving the outcomes we desire, that there is learning around interprofessional behavior, how you work with other professions and how you learn from other professions. We expect teaching staff to be suitably qualified and experienced. So, and our regulator requires that teaching staff are qualified one level higher than what the program of study is. So our programs in Australia are bachelor and master levels. So teaching staff have to be PhD holders, and you need people with postgraduate research capability to help deliver some units, but you have to remember that you're also delivering a clinical program. So you need clinicians and experienced clinicians involved in teaching clinical practice, as well as research trained staff and research experienced staff to help develop a research program in the school, and research skills in graduates for lifelong learning, and research skills around evidence-based practice and so on. And we expect that the environment that supports learning is appropriate for the learning outcomes, and that the facilities and equipment are appropriate for setting up the program and running the program, etc. So there's a set of quality assurance standards, basically. So, you know, as optometrists and as an optometry profession, we need this form of evidence to be able to say, you know, we are doing a good job in training our graduates are competent, they are fit for purpose, and they're fit for developing purpose, or fit for new areas of practice in the future. And that's important. So if we're thinking about the future challenges that things like the World Report on Vision are outlining, what do we have to do as a profession? What do we have to think about? We need to think about what role can optometry play in an individual country's health system. Now, all our countries are different. We can't say we need the US model of practice or the Australian model of practice in a particular country, because it may not be appropriate to that country's particular health system setup. So we as a profession need to identify where optometry best fits into that system, thinking about the role we can play, and thinking about where we can use the particular higher order skills that optometrists have: critical thinking, diagnosis, differential diagnosis, management, communication, advocacy, to their maximum within the healthcare system. And so we need to develop an evidence base that optometry can play a particular role. For looking at optometry being involved in a broader way in ocular disease management, we need to demonstrate that we can do this appropriately and safely, and there is public safety involved in it, and we're going to produce better outcomes. So we need to think about how we develop the advocacy support for optometry's role. And looking forwards 10 years, 5, 10, 15 years, we need to think about our modes and models of practice. What we are currently doing the best model going forwards, or should our role be different? And we need to think about the future of healthcare is going to be around interprofessional engagement and team-based care. So how can we fit in with other health professionals who deliver aspects of eye care, and how we can use their skills and our skills in complementary ways to improve outcomes and improve access. So we need to make sure through education for the future that optometry has the relevant competencies that enable us to practice most broadly and participate most fully in healthcare delivery. So in most parts of the world, outside the well-established optometric countries like the US, Australia, New Zealand, Canada, etc., and the UK, many optometrists aren't trained well in ocular disease and its investigation and management. So there's work to do in developing those skills in optometrists. So we need to do that. And it may mean that we have to demonstrate through applied clinical research and clinical studies and pathway studies that optometrists can do these things safely. And then we may have to think about, do we need to add skills to optometrists who are currently in practice through a process of micro-credentialing, able to undertake certain tasks that they aren't currently trained to do. And that's a role for education to think about. We need to think about legislation. We need to make sure that optometry is recognized as an autonomous healthcare profession at primary level. We need to legislate who can practice optometry. That's a vehicle to protect the public. Legislation about who can practice is not there to protect the profession. It's there to protect the public. We need to argue for legislation that permits scope of practice to be equal to the level of education. So you can practice what you are taught to practice. So if you're trained to do glaucoma management, you should be able to practice glaucoma management. So that means legislation allowing us to have access to the necessary tools, diagnostic ones and management ones. In some countries in the world, optometrists can't use slit lamps, for example. In some countries, they can't do retinoscopy. In some countries, they can't access diagnostic drugs, mydriatics and anesthetics. So we need to make sure to play a fuller role that we have access to the appropriate things. And really, we need to promote the role of optometry in improving and expanding access to services at community level. And we need to make sure optometry as a member of the continuum of eye care, technical people doing some things with supporting the role of optometrists who have the diagnostic and management and thinking skills, and optometry by the same way supporting ophthalmology by taking over management of routine ongoing review and so on, and leaving the ophthalmologists to do their higher order surgery stuff that we are not trained to do. Do we need to still be doing the refractions and driving the field, driving the perimeter, or managing the OCT, using support technical staff to assist our delivery of care and our diagnosis and so on? How can we have those partnerships? That's the team-based care. That's the multidisciplinary team. How we have to partner with government, talk to ministers of health and education, hospitals, clinics, community centers about how optometry can fit into the healthcare system and deliver better outcomes. So it's integrating optometry into the system where it currently isn't, or where it may not be currently. So we need, just to finish up, I think this is the last slide, what we need for the best vision and eye healthcare system in a country is that for all practitioners to be able to work at their maximum scope. We need to work with others and recognize that people have some of the skills that we have at the lower end, and there are people who have a set of skills that are higher than ours in surgery and so on. But we have a place with others supporting us, as I said before, and using our higher order skills. And there's another World Health Organization document that sort of outlines that spread of competencies across eye care workers, and it's called the WHO Eye Care Competency Framework, that you can download from the WHO page, or you can download it from the WCO's website. So really, the message, my message is, as a profession in each country, we need to recognize what our country's challenges are in eye care and how we contribute to overcoming those challenges and meeting those challenges and improve outcomes for the members of our particular society. So we need to identify our role, train appropriately for the role to a high standard, and therefore will make a greater societal contribution. So thank you for the opportunity to speak, and I wish you well for the rest of the conference.